The critical question that I will be answering is, what is the most important role of docusate sodium in the postoperative population? Docusate sodium is a laxative. This laxative is commonly used after surgery to promote stool softening. Constipation is a common side effect of surgery. This is for multiple reasons. It could be correlated to narcotic use for pain, the inability to ambulate and staying still because of surgery, general anesthesia, change in diet. All of these factors contribute to constipation. So docusate sodium is a good alternative to softening stool. So the mechanism of action for docusate sodium is it increases water and fat penetration in the intestine, which results in softened stool, making it easier to pass. Docusate sodium has been known to present with some adverse effects. These adverse effects include nausea and vomiting, abdominal cramping, diarrhea, anorexia, and rash. If any of these adverse effects present, make sure to stop the medication right away and notify your healthcare provider. Keep in mind that docusate sodium can take anywhere from 24 to 72 hours to take full effect. Some nursing considerations that I would inform my patient when administering and advising this medication would be to make sure to drink a full glass of water when taking this medication. That further promotes the action of mechanism, which is increased water and fat penetration in the intestine, which promotes softened stool and easier passage. Once again, a big thing that I would tell my patient would be to stop this medication right away if they are experiencing any of the adverse effects that you instructed them on. Hi, my name is Blaze Harrington, and today I will be completing an abdominal assessment. I will have a patient that is presenting into my healthcare facility with concerns of abdominal pain and distension. I will take their subjective reports and my objective knowledge and complete a focused abdominal assessment. Hi, my name is Blaze, and today I'll be your nurse. How are you feeling today?
Not good. My stomach's hurting.
Oh, your stomach's hurting?
Yeah.
Okay, and what makes that pain better or worse?
Just staying still.
That makes it better?
Yes.
And what makes it worse?
If I move around at all.
Okay, and what does that pain feel like? Is it aching, stabbing, cramping?
It's cramping, yeah.
Cramping? Okay, and does that pain spread, radiate, or move to another location?
No, it's just right here.
Okay. And on a scale, right there?
Yes.
Okay, could you lift up your shirt and show me? Okay. And on a scale of 1 to 10, 1 being no pain and 10 being the worst pain you've ever felt, what would you rate it as?
But around a 6, I'd say.
A 6? Okay, and is it always a 6?
Yes, all the time.
Okay. And when did this pain start?
Around 2 days ago.
2 days ago? Okay, and has this pain been intermittent or continuous?
Continuous.
Continuous. Okay. And what do you think is causing this pain?
I haven't had a bowel movement in around 2 days.
Okay. So to clarify, your last bowel movement was 2 days ago?
Yes.
Okay. And how has your diet been? I see your tray is untouched.
I don't really have an appetite either.
And did that start 2 days ago as well?
Yeah.
Okay. Do you have any allergies or food sensitivities?
No.
Okay. Are you on any medications?
Hydromorphone 1 milligram.
Okay. So the first step of the assessment process is inspection. So I'm going to ask that my patient raises their shirt, and I'm going to inspect the abdomen. So I'm looking for several things here. I'm looking to see if there's any lumps, any bumps, any masses. I'm looking to see if there's any redness, any rashes. I'm also looking for symmetry of the abdomen. Is one side of the abdomen higher than the other, or the other way around? I'm also looking to see if the abdomen is rising and falling as my patient breathes. I'm also looking for any pulsations over the abdomen. I'm also looking for things like striae, which is stretch marks. I'm looking for lines. Do they have a G-tube? Do they have any wounds? The next step of the assessment process is auscultation. To auscultate, you'll need a stethoscope. So I'm briefly going to explain the anatomy of the stethoscope. So there are 2 sides to the stethoscope. You have the bell, which is the smaller side, and then you have the diaphragm, which is the larger side. Throughout this assessment video, I will tell you which side to use to auscultate each section of the abdomen. So the abdomen is separated into 4 quadrants. You have the right lower quadrant, right upper quadrant, left upper quadrant, and left lower quadrant. I will show you those quadrants on my patient. So here we have the right lower quadrant right down here. We have the right upper quadrant right up here. We have the left upper quadrant right over here. And then we have the left lower quadrant over here. So in terms of auscultating, I will have to auscultate all 4 of those quadrants. So I'm going to use the diaphragm, the large side of my stethoscope, and I'm going to auscultate all 4 quadrants of the abdomen. I'm listening for bowel sounds. So starting in the left lower quadrant, be sure not to touch the bell of your stethoscope because you may formulate sounds by touching it. So I can hear that my patient's bowel sounds are present. They're not hypoactive or hyperactive. Hypoactive means slow. Hyperactive means fast, and there's a lot of them. So once again, my patient's bowel sounds are present in all 4 quadrants. Keep in mind, when you are auscultating for bowel sounds, you should be hoping to hear anywhere from 5 to 30 bowel sounds per minute. The next step of the assessment process is percussion and palpation. So first we'll start off with percussion. So percussion involves that you use 2 fingers and you hit these fingers off of the joints of your other fingers. This enables the nurse to hear if there's tympany and dullness and measure the size and border markings of organs. It can also help you determine if there's fluid in the abdomen or the surrounding organs. So first I'm going to get my patient to raise their shirt. And like I stated before, the abdomen is separated into 4 quadrants, so you're going to percuss all 4 of the quadrants. So me percussing, it generated a tympany, which is what you wanted to hear. If there was dullness, that could indicate that there was fluid or you're hitting over an organ or like a rib. So next what we're going to do is we're going to percuss for the liver and trying to determine the liver border. So like I said before, the liver is on the right side of the body, or abdomen, sorry, could you just place your arms down? Your arms down. Is on the right side of the body, so we're going to percuss here. We're going to start from the bottom and make our way up slowly, listening to the change in tympany to dullness. So what you have to keep in mind when percussing the liver is that the liver is partially covered by the ribs. So when you get up to the ribs, you're going to want to place your fingers in the intercostal space to avoid percussing the ribs. So with that being said, that actually presents our other assessment part, which is the spleen. So the spleen is completely covered by the ribs. So like I said before, you'd have to place your fingers in between the intercostal spaces to get an accurate sound. Following percussion is palpation. So palpation requires a couple of different things. So what I'm going to do first, I'm going to take both of my hands and I'm going to place them on my patient's abdomen. I'm doing this to get a better sense of my patient's temperature. So by doing so, both hands on both sides of the stomach, I am bilaterally testing the patient's temperature of his abdomen. It feels warm, his skin is moist, he's not sweating profusely, he's not really, really hot or really, really cold. So now I'm going to begin palpation. So there's 2 types of palpation. We have light palpation and deep palpation. So with light palpation, or all sorts of palpation, there is a specific rule. So if my patient did present with pain in the lower right quadrant. So I am not going to perform deep palpation on that quadrant because that would just promote my patient's pain, and that is not my goal. And I will palpate that section last. So I will do light palpation over that section, but I'm going to proceed with caution and make sure my patient is comfortable at all times. So I'm going to commence with light palpation, not starting in the place where my patient reported pain. So while you're palpating, you want to make sure that you're feeling for any lumps, bumps, or masses, any fluid shifts, air shifts. And you're also going to be making sure that you're looking at the patient's facial expressions. Is the patient grimacing, especially over the place where he reported pain? Okay, so now we can move on to deep palpation. So we're going to start not in the place where they reported pain. We're going to start over here, and we're doing deep palpation. Once again, looking at facial expressions. Okay. Okay. And we are not going to deep palpate the painful area. Okay. So that concludes palpation. That concludes my abdominal assessment. I'm quickly going to summarize my assessment findings. So my patient voiced concerns of abdominal pain and distension. He stated that his pain was a 6 out of 10. He stated that it was a continuous cramping that started 2 days ago. My objective findings support that the patient was 3 days post-op. His vital signs were stable. He was using hydromorphone 1 milligram as an opioid for pain management. He did not have an appetite, and his appetite subsided roughly 2 days ago, and his last BM was 2 days ago. So my assessment findings uncovered that the patient had moderate pain, 6 out of 10, in the right lower quadrant. This was also accompanied by a mild case of abdominal distension. So the plan for my patient is to use docusate sodium as a laxative to soften the stool. I have also suggested to my patient to increase his water intake to help the mechanism of action for that medication. I have also instructed my patient to try and ambulate as much as he can after surgery, but safely, as safe as possible. I have also advised my patient to try and stick to a clean and fibrous diet that will also help pass stool. Thank you for watching my abdominal assessment.